welcome to the Voyage Clinics podcast. I'm Dr. John, your host. Today, Dr. Lee Trotter is joining me. He's a general surgeon, pediatric surgeon, bariatric surgeon, and he's fantastic. We've done a podcast together. We talked about appendicitis and cholecystitis, which is gallbladder. And today, we're going to talk a little bit about a few other types of surgeries. We were just chatting a little bit before this, and Lee's was on call. He's post call, and he's had a few hours of sleep. And I asked him about his day, and he says, "Every day is a good day. Some are just harder than others." And he's just spoken like a true gangster general surgeon. So I appreciate you, sir, and thanks for joining me today.
It's a pleasure.
Let's talk a little bit of shop here.
All right.
Can you just speak to the endurance of like that mentality of resilience? I just briefly, you've gone through the trenches. People don't understand gen surge or even some of these surgical subspecialties where you're on call all the time, like not sleeping well, and you're still grinding it out. You're doing it.
Yeah, I'm probably like saying I'm not saying this is smart, and anybody should do it, particularly your surgeon. But I'm kind of the last generation where we were called residents in a hospital for a reason, because you basically live there. And I in my program, we'd go home every third day, and they'd say you'd get home about 9, 10 o'clock at night, and they'd said go home, shower, change your underwear, you got to be back by 4 a.m.
Yeah.
And, I'll tell you, I was young back in those days, and I could do it really pretty well. But you had to kind of build up to it to where you could go a couple days without sleep and I guess live on adrenaline. As I've gotten older, it's gotten much more difficult. But anyway, no, that's our lifestyle. A lot of people, my mom didn't tell me this side about being a doctor, and it's, you don't do it because there's money in it. That's actually, the money part's been stripped out over the last decade or two. And now most of us do it because of the love for it. Yeah. And we just, if you didn't, you wouldn't do what we do. It's not worth it. Either you can make money, and I should say make a living to support your family doing 100 other things. Medicine isn't it? It's what I term a calling. And, I teach. And so we've got residents and medical students that come in, and the med students in particular, they'll come in and they'll complete a rotation, and I got to give them a grade. And they'll usually ask me something like, "So do you think I should be a surgeon?" And when they ask me the question, I just straight out, just very quickly, no. And they think, "Well, didn't I do well?" And I said, "No, it has nothing to do with that. If you have to ask me if you should be a surgeon, the answer is no, because you have to have the mindset that it doesn't matter what you think or anybody else thinks. I'm doing this. I hear the call, and I will do whatever it takes, and it comes from within you." Yeah. And that's why we do what we do. And, we try to do the very best for all of our patients, and we're people too, and we get tired. And I already told my staff I was a little grumpy yesterday because I'm on 2 call days. Oh, gee. This has been back to back. So I've gotten about 2 hours of sleep 2 nights in a row. So I'm working on, past 48 hours with less than 4 hours of sleep. But I'm not saying this to complain. I'm just saying that sometimes, I got a little grumpy yesterday, and I told him, I said, "I'm sorry. I'm just like really, I have no fuse." Yeah. But anyway, so everybody, if your doctor is just maybe a little grumpy, he may not have slept for a day. That's right. But he's still going to take good care of you.
That's right. I remember for a decade, I delivered babies and worked in the hospital and took call and did all these things. And you would get woken up several times throughout the night, and sometimes go in and labor all night with the baby and mama. And I remember getting, the next day I've got a 1 hour of sleep, 2 hours of sleep, and going in the next day full clinic. And you're right. It's not, the money's not there as far as, I'm not making millions of dollars. I don't think any doctors are anymore.
No.
But it is really rewarding, and it's really satisfying to take good care of people. And that's like your core value. You get good care, and even if the doc's a little grumpy, you're still going to get good care.
You're still going to get good care, and we do the very best that we can. And I say I love what I do. If you say I said this, I'm going to deny it, but I do this for nothing. I really would.
You're going to strike that from the record.
Yeah, just delete that. Delete that. But no, we really do. And
it's true.
And I work with a lot of really great docs who truly dedicate their life. And, I'm in my 60s now, and I'm unfortunately, I have 5 children, and I didn't perhaps have the wisdom back then, and I was all medicine. I mean, I was all in 100%, and my family took a beating. My kids took a beating, and here they are now adults with their own kids, and I'm kind of getting some blowback. It's like, Dad, where were you when I, had my football game, or where were you? And I all of these things that I wish I had as a parent, as a father, I forfeited all of it for medicine. And I mean, I loved what I did. And at the time I didn't realize what sacrifice what my family was making. So it's not just me, it's the families of the physicians that carry the load.
My wife called herself the med school widow, residency widow.
Exactly.
And it was tough because we were just out of the picture. And finding that balance, I have 2 at home still. So I've definitely shifted gears and struck a better balance there. But I think I'll make up time with my grandkids.
Well, you will, but I'll tell you, you're way ahead of me. I learned after I had grandkids, and I just know I guess my pitch is that the docs, it's 100%. You're all in. I read daily and just trying to keep up and take care of my patients and all that. But there's a backside to it. And it's our families, and they're every bit a part of allowing us to do what we do. I always made the comment that I said, when I go home, I have magic drawers. Every time I open them, there's like clean socks and clean shirts. I mean, they're magic. Yeah. It never, it was always that way. And of course, I'm referring to my wife and the dedication and really hard work that she was a widow for my whole career.
It's a good shout out to the people that matter the most. That's good stuff. Let's talk a little bit about surgeries. Let's talk about a very common one that we see all the time. We screen for it in family medicine, there's sports physicals, and as a doc who takes care of all age groups, I see hernias in kids, I see hernias in little babies, I see hernias in older people and in athletes. And so let's talk about hernias.
All right. Well, let's define what a hernia is, because it's, everyone says a hernia, and they're talking about a hiatal hernia or inguinal hernia, umbilical hernia, femoral hernias. There's lots of different hernias. So generically speaking, think of your abdomen is a cavity, and it should have a roof and ceiling and foundation, and it should be complete, and there should be no holes in it. And a hernia is where there's going to be a hole. So if it's on your belly wall and it happens to be at the site of your belly button, and you can actually put and feel the defect. You'll push your finger, and like a lot of you might want to push on your own belly button, and if you can feel a little rim, that's a hernia. It's an actual hole. So the stuff from the inside, which could be a piece of fat, it could be intestines, can actually pooch through that little hole, and now it's not in the cavity anymore. It's outside the cavity, and so that hole is a hernia. And they can, depending on their location, is what gives it its name. So inguinal hernia is inguinal, or refers to the groin. And in the groin, there's a few different types that it doesn't really matter. The docs care about it, but as patients, you don't need to know if it's like femoral or indirect or direct and all that. It's a hernia. You just got a hole. So that's a hernia. Hiatal hernias are a little different. They're very common, and they don't need to necessarily be treated, but that's where part of the stomach comes up through the diaphragm. So that would be the ceiling, if you will, if you were standing up. Your diaphragm would be the roof or the ceiling of that cavity. So, and those in and of themselves don't need to be treated per se, but maybe we get into that a little bit later. So let's, I think it'd be easiest to break hernias down into the most common, which let's talk about umbilical and inguinal hernias. That's going to be the most common. I mean, that's going to be 90% of your hernias. You're going to see them in both male and female. A little more frequent in males, because they've got a spermatic cord that comes out, and gals have what we call the round ligament of the uterus, but it's a lot smaller structure, and so they usually don't have the hernias as frequently as a guy will. But so let's talk about those two hernias, the umbilical and inguinal. And let's start out first by going by age. And we'll talk about the child first. And so let's talk, to be born with an umbilical hernia is not uncommon. In fact, a lot of premature kids, the majority of them will have umbilical hernias. And if a child has, and when I say a child, I'm talking like less than 5 years of age. If they have an umbilical hernia, no worries. We don't worry about them. It's very uncommon for them to become incarcerated. What that means is like bowel or something has come through the hernia and now it's stuck. I can't push it back in, so you feel a lump on the skin. You don't feel the hole. It's just a lump, and it might even be a tender lump, which would suggest that you need medical attention now. If it's really tender, that's like immediate. If it's just won't go in but it doesn't hurt, it's like make an appointment for this week kind of thing.
Yeah.
All right. So if you're less than 5, child, and you have an umbilical hernia, we don't really worry about that. Now, if you get up to about age 5, or they're just getting ready to start school and they still have an umbilical hernia, we generally now fix those. And quite honestly, I think that age came up because of school, and we wanted to fix it so they didn't lose school days and stuff like that. And typically, if you have it at age 4 or 5, you're going to have it at 10, 11, or 12, or 20, whatever age, because 80% of them will close by age 4 or 5 on their own. So that's why we don't fix them right away, because the majority of them will just heal on their own. Now that's
been my experience. There was who was it? This was maybe a really, really old school doc who recommended taping a silver dollar to it.
Yeah.
This is like the old, like. There's a lot of old wives' tales with stuff like that, and you really don't need to do that. It scars down on its own. If it's going to heal, it's going to heal. If it's not, it's not. And taping a quarter, a nickel to it isn't going to change the healing process. And that also goes to we term them hernia belts, things that you can commercially purchase. I don't recommend hernia belts for anybody, any age, for any reason. It doesn't fix the problem, and it actually can cause more troubles because it puts pressure. The hernia comes out, and now you're pressing on the bowel up against the abdominal wall, and cause swelling and actually make things worse. So I don't recommend them at all. So anyway, we kind of digressed on that a little bit. But okay, so we did the umbilical hernias for kids. Adults, if you're over age 5, umbilical hernias, they don't have to be fixed, but they usually just keep getting bigger with age. And certainly if they're symptomatic, meaning you're having some tenderness in the area, they need to be fixed. These are same-day surgeries. You come in and I mean, literally, it's a 15, 20-minute case, a couple stitches. If they get bigger than about an inch, sometimes we'll put mesh in them in adults to reinforce. We don't use mesh in children. Mesh doesn't grow.
kids do. And then you end up with a little piece of mesh in a big kid after 20 years of growth, and the mesh isn't doing anything at that point. So mesh is typically not, well, it's not typically, it's rarely, if ever, used in a child. Now, inguinal hernias in children are a different story. And this includes, premature newborns. Inguinal hernias need to be fixed when they're identified. Not necessarily emergently, but if you see a bulge, and a lot of times mom is who identifies and diagnoses the hernia. They may not put the word to it, but they'll say, I was changing Johnny's diaper and this side looks different than that side. There's a lump. And and when he cries, it gets big. It gets way bigger. And they'll come in with that story, and what they're describing is a hernia that's coming in and out of that hole. Mm-hmm. And those need to be, fixed. And again, not an emergency like I need to run to the ER to get it looked at. If it's going back and forth, it's, talk to your primary care provider, your pediatrician, and they'll get you set up. Yep. And you'll see generally pediatric surgeons take care of pediatric patients, and it's not often that you'll see an adult general surgeon want to repair a hernia on a child. Mm-hmm. So you'll need to search out a pediatric surgeon that specializes in the little ones. Yeah.
I've sent many of these to you.
Yes, yes, you have.
And so I'm going to circle back on umbilical hernias briefly in the adult population. Say someone's in their 30s, 40s, and they develop an umbilical hernia, small, not painful, and then growing over time. And I see this often with my kind of abdominally obese people. They've got a lot of visceral fat, and it's kind of just pushing over time, and then eventually just kind of
sure. Out. There's the thought process has kind of been evolving. When I was, resident, we're talking some 35-ish years ago, you had one, you got it fixed. End of story. Inguinal hernias, umbilical hernias, you just got it fixed. And I don't know if it's been economic pressures or whatnot. We've kind of backed off on the aggressiveness for these repairs, for the asymptomatic small little hernias. And, I tongue in cheek on the small versus large. Sometimes the smaller hernias are more dangerous than the bigger ones. Stuff gets pooched out of the little ones and it won't go back. Whereas big defects, stuff you can drive a truck back and forth and they don't incarcerate. Yeah. They don't strangulate because they're so big. So don't let the size in and of itself be the determining factor of whether it's repaired or not. But I think we can safely say across the board that all symptomatic hernias need to be fixed.
With somebody with an umbilical hernia, they want to get it repaired. Would you recommend some weight loss prior to repair just to avoid that?
Oh, if you're a little on the heavier side, one of the recurrence is probably the biggest complication that we're going to have, and the biggest factor for recurrence is your weight. And I mean, just think about the mechanics. If you're heavier set and you're pushing out on a repair, that's the weak spot. And you're just going to blow through it. And that's why a lot of times, if it's more than about 2 centimeters or roughly an inch, we put mesh in all those people. If it's larger than that, because a 2-inch defect, you can sew it together and they're going to laugh, cough, they're going to bend over, pick something up, and those stitches are going to just tear right through the tissue. So the fabric, you'll never know it's there. Your body grows into it and it becomes part of you. And
abdominoplasty, like superior versus like the mesh thing? For like fixing an umbilical hernia?
Well, we would put mesh in to fix that. Abdominoplasty is a whole separate. Now, this is a little trick. And again, for insurance companies, I'll deny I said this, but if you've got a big pannus and you have a hernia in the midline, insurance companies don't tell us where to put our cut. And what I choose to do, because I do, with my bariatric practice, I've got a lot of folks with a lot of abdominal skin hanging down. So I do a lot of abdominoplasties or tummy tucks. But what you can do is if you have a hernia, I can make the incision down low, which is a tummy tuck incision, a bikini type incision, lift the skin up, fix the hernia, pull the skin down, and I don't know, somewhere during that surgery, a bunch of skin disappeared. And then, we sew it back together, and we can get the lion's share of that skin removal covered by the hernia surgery. Nice. And so it's a little trick. And so if you're talking with your doc, a lot of general surgeons aren't going to do it because they don't do tummy tucks. So, but there are a bunch that do. Yeah. I'm just throwing it out there. Yeah. Be aware.
This is a great pearl.
This is just something, and that's what I do for my patients is they've got a umbilical hernia, and a lot of my bariatrics hope they get hernias because then they use that diagnosis, and I just choose to put my incision in a bikini area versus up and down in the middle, which it doesn't allow you to really remove the skin. So just a little trick.
Tricks of the trade.
Yeah, there you go.
Thanks for sharing the pearls.
Yeah.
Okay, we were on inguinal hernias.
Inguinal hernias.
And we were talking about them in the pediatric patients. Get them fixed. There's no question.
You just get them fixed. You get them fixed when they're diagnosed. And if it's not going back in or if it's tender, that is not something you wait till tomorrow or next week. If it won't reduce or you can't get rid of that lump, and to do it, lay on your back and just kind of relax for a minute and then just gently massage the lump. There's not hard pressure. Pushing harder doesn't make it go in. It's got to be gentle massage with just light pressure, and you'll feel it. It goes bloom.
It reduces.
It reduces. It feels. People will go, "Oh, that feels so gross." I mean, but that's just the bowel going back into its native location.
And it does make that sound.
It does. It does. It does. But, and if it does that, then you're fine. And that's, call your primary care doc and they can get you set up with somebody who can repair that. If it's not going back in and it's becoming tender, that's something that you go now. That's what emergency rooms are for. In the middle of the night, you go in because you're on a time clock if you're going from incarcerated, meaning it won't reduce. You can't push it back in. Goes from incarceration to strangulation, meaning the blood flow to whatever's pooching out. The blood flow is now getting cut off because it's swelling, and the defect doesn't swell. The defect stays the same size, but the bowel or whatever it is, it does swell. And as it swells, it just chokes itself off.
So what is the time clock? I've heard 90 minutes. I've heard 60 minutes.
Well, it's, I'm going to be hard pressed to give you time. Yeah. I can just tell you if it's getting tender, it's get in the car, go now. You don't finish the last episode of your mini series. Yeah. You just do it.
So a few months ago, I had a guy, he was up on the mountain, of course. Luckily, had cell service. And luckily, I give all our clients my cell phone. So they can text or call if something goes sideways. And we knew he had a hernia, but he was like, still working on getting in and getting it fixed. And we had talked about this. We had talked about it's incarcerated, strangulated, and when to go. And he started having pain in his hernia. So he calls me on the mountain. He's like, Dr. John, I got this hernia. It's starting to hurt. And I said, well, you got to come down the mountain. He's like, but we got the camper set up. The kids are here. The wheelers are out. And I said, you got to go in. And he's like, but? And I said, no, you got to come down and go in. About 10 minutes later, he's like, I'm on my way in and it hurts like a son. Yeah. And I said, okay, we really got to get there. So anyway, he was able to get in within 30 minutes, and they got him squared away in the ER and called in the surgeon and got it fixed.
Got it fixed right away. You bring up a good point, and this gets to, do all inguinal hernias need to be fixed in adults immediately? And again, before the answer was yes, unequivocally yes. And there's some literature out there to support that if it's completely asymptomatic, maybe we don't need to fix all these immediately and wait till they give you grief. But I'm going to throw out the yellow flag on that one, particularly for people who are very active and who go out into the woods and go camping or go, on a European cruise or, these kind of things where you're in environments that are a little more austere, where you're not you don't have the reliability of good care or any care. And that, it's, you're just kind of a time bomb, in my opinion.
This guy lucked out. I mean, he really lucked out. He happened to have camped in a spot where he got 1 or 2 bars, and it's a big deal.
It's a big deal. So anyway, if you have those, take into consideration your lifestyle. Mm-hmm. If your doc says, well, you're completely asymptomatic and, we can just watch this for a bit, that might be a good idea for somebody who sits in town and doesn't do much. But if you're really active, I think you need to put that in the equation. And just to be safe.
To your point, when I was in residency in Jacksonville, Florida, we went to Haiti and did a medical mission trip every year. And one of them was a surgical mission trip, and we did inguinal hernia repairs because in a third world country where they largely carry their water, this is a life-ending thing. In America, where maybe they're less active, it's not as big of a deal to just fix right away. So we just did one after the we were just fixing hernias all day.
We generally, when I have patients come to me with hernias, I generally just recommend repair.
Yeah.
It's the safe thing to do.
Can you speak to style of repair briefly?
Yeah, we can talk about that. When there's 50 different ways to fix something, it should tell you that there's not a perfect way, that, there's a variety of ways. And that's kind of with inguinal hernias. Over the years, we've done just straight tissue repairs, which we still do today from time to time, depending on the situation. If there's infection in the field or near it, we will not use mesh. There are situations that dictate whether we use mesh or not. I think by and large, all hernia repairs today are mesh-based. I know I'm going to have some critics say, oh, man, if you did Scholdice repair, you don't need that. We have just as good as results. And I guess if you're Dr. Scholdice, that's probably true. I'm not. And, and I couldn't repeat his results. But anyway, I think by and large, the mesh repairs are tension-free. They're less painful, people recover much quicker, and by and large, the recurrence rate is quite a bit less.
Any problems with the mesh? Rejection?
I've
heard fussiness about.
Well, this is anybody who's watched any commercials on TV. You've got the mesh. If you've got mesh, call 1-800-lawyer. And for inguinal hernias, umbilical, and just hernias in general, those mesh commercials are not referencing these kind of products that we use. There were perhaps some bad mesh products that had plastic rings around the mesh that would break and then leave a sharp edge that could perhaps, but those have been long since pulled off the market. We don't use those. So when I refer to mesh today, I'm talking just the generic, mesh products, Marlex mesh or Prolene mesh, these kind of things. Anyway, so we usually use them. There's a few different products out there, and your surgeon is going to be very comfortable with what they use, and it's probably they get good results, and I wouldn't question this product versus that product. Of course, I have my personal opinions, and I use the ones I use, and I've got my reasons, and I think I get great results, and I do. And so that. Now, as far as the question of rejection, these materials are inert, meaning They don't react to your body. Your body doesn't even know they're there. The idea that you're going to get chronic joint pain or these immunologic long-term things like, say, with the old issues with the breast implants, things like that, that people had systemic disease from artificial material being put in them. That is not the case with mesh. This is truly, to be honest with you, it's fancy fishing twine.
Yeah.
It's polypropylene. It's just what we use for fishing line, and it's in a weave. And your body, it looks like a screen on your screen door, and your body grows through all the little tiny holes. And so your body just incorporates it. Now, there is an issue with infection. If it does get infected, it's a disaster and it needs to come out. But that's very unusual. We typically would give a IV antibiotic prior to using a mesh product. It does have a lower infection rate. And if there's any infection in the field, we don't, there's other kinds of mesh we use. We don't use those, we call them just non-absorbable mesh. That's 1,000 years from now, you'll be a pile of dust and there'll be a little piece of mesh where your groin was. That's the kind of mesh, that we use. There's biologic mesh, which is actually made from a tissue source that gradually disappears. It's extremely expensive, and we can use those in infected fields and things like that when we don't have any other options. But
this is good to just have a definitive mind on the mesh situation. We did an episode on placebo and nocebo, and placebo being like, I trust what you're saying and it's going to happen that way. And then it does happen that way. And nocebo being, I don't trust what you're saying. And I'm sure this mesh is going to cause rejection and autoimmune disease and these things. And it actually can come to fruition. Like, you can nocebo yourself into sickness. So it's wonderful to hear the definitive science on meshes right now is that they're very good. They're inert. They're not going to cause these kinds of problems. If they get infected, yes, disaster, we'll fix that.
Correct.
And that is very, very small chances. So just from my clients, from me, it's very, very unheard of.
You're going to need to be told that mesh was used, because you're not going to know if by feeling it, by your experience in life after hernia repair, you're going to have no clue. And if your doc didn't tell you if there's mesh, you don't know.
Yeah.
So that's they say. Now, for me personally, if I had an inguinal hernia repaired, I'm getting a mesh repair, straight up. End of story. Yeah. It's not even a question. I think the advent of meshes has revolutionized hernia repair. It's a game changer. And when I started, we didn't have mesh. It was, not available. And when it came out, it was really expensive. And so we did regular, what we just call tissue repairs, sewing tissue on one side of the hole to tissue on the other side of the hole. And you can imagine if you had a hole in your jeans, and you're sewing one side to the other, the fabric right by the hole is weak also. And it just gradually tears apart, and then you get another hole. Yeah. And then you get redo surgery. And I would rather have it repaired right the first time than it's like, do the first surgery, or what is it? Do the second surgery first and not have to repeat it.
Dr. Trotter, can you speak to some of the fancy minimally invasive robotic Da Vinci?
Now you're getting in the weeds with me. Let's go. All righty. So now I'm going to disclaimer. I have been robotically trained and I can fix these robotically. I on earth don't know why nobody can talk me into doing it. Now my partners do it robotically and I make fun of them. They make fun of me because I don't. And so we have a nice banter back and forth. Should you, shouldn't you? Is it right, wrong? Is it a better repair? And the answer I'm going to tell you is no. There's no literature to substantiate the fact that a robotic hernia and we're going to talk primarily inguinal, although robots can be used for other hernias as well. But for inguinal hernias, there's nothing that would suggest that that is a better, longer lasting, more robust repair than any of the other repairs.
What's the alleged upside? I mean, is it like...
Well, I think it's all downside.
Yeah.
That's why I make fun of my partners.
Okay.
Now, and I'll tell you my reason is when I do mine. Now I've done them, so I'm embarrassed to say that I've done these, and the reason that I say this is when I do my inguinal hernias, I make a 1-inch cut that's probably maybe 2 inches at the most, a little incision right over the hole. And I go to the hole and I put the mesh in the hole and I'm done. And it's 1 incision and I don't make any holes. The robotic, the laparoscopic, they typically have to make 3 holes in your abdomen.
In the fascia.
In the abdomen itself. They make holes through your muscle. And so you're making 3 holes to go fix 1 hole. And then you have a risk for those 3 holes that they're going to form a hernia later on if they don't heal completely right. So, and that's always going to be a weak spot. Whenever you make a hole, even though you sew it up, it's inherently weak, and it will always be that way. So my position is, why would I make 3 weak spots to fix 1 when I can just fix 1 and not make any?
Yeah.
So that's my position, and
I like it.
and we argue, and I'm not going to say that.
Is it faster recovery?
No, there's no recovery difference. No.
It's one of the allegations.
No.
Minimally invasive.
It's minimally invasive. No, there's nothing. I will disagree with everybody that thinks that the laparoscopic or robotic, it's the same kind of thing, has a quicker, less painful recovery. Mm-hmm. There's nothing to suggest that.
I'll say that I had a patient who did this, and it was a $26,000 bill with the robotic, as opposed to maybe 3 to 6 without. And so that's tough. We're kind of mindful about cost with my practice. Is kind of the way we operate.
As are we. And not only the cost, but the time. I can literally probably do. Now this, and again, all surgeons are different, and how fast you do a surgery doesn't mean you're a better surgeon. In fact, if you're trying to go fast to be a surgeon, I think you're in the wrong field. That's when you slow down and take your time. So I'm not trying to say that speed is a metric to good surgery, but by the time you get the robot, there's a lot that goes into that. You have to make these holes. You have to dock the robot. It's big, and you have to pull it up to the patient, dock it to the patient, get the arms of the robot hooked up to the instruments, and then the doc's got to walk around, go to the console. So the doctor's is like in the corner of the room operating, and the patient's in the middle of the room. And they always have a technician who's scrubbed because they got to change out instruments and put mesh in and do different things. So, but by the time you get all of that done, even guys who are just reasonable speed, I could probably do 2 hernias or maybe 3 in the time that they do 1. Now, and I don't know this.
Is that time under anesthesia, by the way? Because
you're asleep, and when you're talking about $70, $80 per minute is what it costs to be in the operating room, and those costs are only going up. Yeah. And, it's an expensive procedure. But then they'll say, oh yeah, but it's teaching the doc who does robotic surgery how to do robotic surgery, so then they can do the more complex surgeries that the robot may have actually some utility for. So it's kind of a training procedure, if you will. So not that I'm not suggesting that the patient's a guinea pig, and that's not the case. That's not the case. This is just a different way to fix hernias. But if you can fix a hernia and do it well, and get training and get comfortable with the robot, it's kind of maybe a win-win.
I love what you said. I think it's beautiful in medicine that doctors can disagree. I think that's beautiful. And I think it's beautiful that we can have friendly banter about it and say,
And that's what we do.
The orthopods, right? They're doing their knee scopes and they're all teasing, the one guy's like, come on, dog, that stuff don't work, and the other one's like, come on, I have 3 studies that support it. And like, I got 10 that don't. And it's wonderful. It's science. And science is a moving, evolving.
It's a living thing.
It's a living, beautiful organism.
Yeah.
And I think that's really cool. And some of it is like nuance to surgeon, like, this is my preference. This is what I've done for a long time. And this is where I'm comfortable. And this is where I'm not. And so, that's really cool insight. And I just appreciate that. And I love science that we can have some
and because it's like that, I'd like your audience to just understand if you go to your surgeon, he's going to get his best results a particular way. Yeah. And I wouldn't request and say, oh, I want you to do it this way because I read on the internet or I heard this Trotter guy say, that's, you shouldn't be doing that. And pressure them to do a procedure in a way that they don't get their best results. Now, if they're getting really good results robotically, then do it robotically. Totally. Yeah, I'm not saying no on that. I'm just saying that we do banter about it, and I don't, if there's 10 ways to fix it, obviously there's not the best way. The best way is the way your surgeon gets his best results.
In medicine, there's an interesting phenomenon that all doctors can vouch for, where rare things come in 2s or 3s. Like you won't see something for 10 years, and then all of a sudden you'll see 3 of them in a week or 2 weeks.
Yep.
It is a strange, interesting phenomenon, but could you say you've seen stuff like this?
Oh, without a question. Yeah, it's like
it's interesting.
Yeah.
So one thing that I've seen recently is these Spigelian hernias, and I just recently saw 2 or 3 of them in the office, and they're not very common.
They are not.
Do you want to speak to those briefly?
Okay. Well, a Spigelian hernia, it's an anatomic. Again, it's out to the side, kind of about typically your belly button level, and it's going to be out, lateral to that. And it's different. It's interesting because it's not it's a hernia, but not complete. So it's difficult to diagnose.
Exactly.
And your belly wall is made up of 3 layers. And the Spigelian can go through 1 or 2 layers, but it doesn't go through the 3rd. And so the hernia is actually between muscle layers, and it's very difficult to feel it. So patients can come in symptomatic saying, oh, it really hurts here. And you're trying to feel that defect, like I said, talked about on the umbilical hernia or even an inguinal hernia, where you can feel an actual ring defect. In these Spigelians, you don't. And they're weird because your abdominal wall is very unique, and that is a point of transition, the way some muscle, the fascia, the covering of the muscle kind of goes down and back up. And it's for us, it's an interesting anatomic transition point in our abdominal wall that I'd have to draw it out for you guys to really
get. The Spigelian line and what happens there.
And what all happens there and all that. Just suffice it to know they're not very common, and it's a hernia between muscle layers, so it can.
Does a CT abdomen pick it up?
It can. Contrast? Yeah, let's talk about. The answer to your question is yes, qualified. A hernia as a whole, in an ultrasound or a CAT scan, an MRI, typically doesn't see holes. They see things in the hole. So if you did a CT scan with somebody who had a hernia, but everything was out of it, it's not likely the hernia is even going to be seen, because it's like a black hole. There's nothing there to see. But if there's something that's in it, so when I have a piece of fat, I've got a piece of intestine or something that's actually in the hole, that's how we diagnose it. But so remember, all these studies are snapshots in time.
Yeah.
It's like taking a picture. Boom. It's what it was that second. And if the hernia was reduced, that second, you're not going to see it. If you coughed 1 second later and the scan already went past that and it pooched out, you're not going to see it. So you got to catch it in the act.
I see.
Yeah. So don't.
Spigalian, sneaky little guys.
They are, because they can come in and out too.
Yeah.
They can come in and out too. So patients that have recurrent pain, we can say, we'll go through all these different things and we'll study them, and it keeps coming up negative. And so ultimately what happens in these patients is all of the studies are negative. We believe our patients, they're having pain and it's intermittent. And what we'll do is, there's nothing more we can do except an exploration. And now the explorations actually are really simple. I can make a little tiny cut in your belly button, put a scope. Now you're asleep during this. Put a scope in the abdomen and look at that cavity, and I can see the hole. I can see the defect. And then one step further, now that I can see the defect, I can put the scope, there's a light on the end of it. I can put it right at the hole and it transluminates. So I can see the light on the skin and make the incision exactly where the hole is. Oh. So now I get a much smaller incision that's strategically placed and make the diagnosis. And we do it all at the same time.
Oh, cool.
Yeah. Okay. And then that would be, again, we would probably use mesh to repair that. If it was really small, we might just repair it with just suture.
That's great. Those are good pearls. I appreciate that.
Yeah.
Can we, any more hernias? I think we've covered most of the basics.
The hernias. Let me just talk about hiatal hernias because that comes up a lot. We don't fix hiatal hernias just because you have a hiatal hernia. And a hiatal hernia is where part of the stomach pooches through the diaphragm and gets up in your chest. So you got a little bit of stomach above the diaphragm, the rest of your stomach below the diaphragm. In normal people, all the stomach should be below the diaphragm. So that little hiatal hernia, and sometimes they'll be referred to as sliding hiatal hernias, where they kind of slide up and down. They're there 1 second, gone the next, back and forth. Now, you'd say, well, why don't you fix them? Well, because they don't do anything, a lot of them. I always say they're a dime a dozen. In fact, I wouldn't even give you a dime for a dozen of them because everybody seems to have a little one. Now, you say, well, what about heartburn? Are they associated with heartburn? And I said, well, they can be. And if you flunk all the heartburn treatments and go to have surgery for heartburn because you flunked your medical therapy, we do repair the hiatal hernia as part of the heartburn surgery. So I've got people with hiatal hernias that have heartburn, and then I've got people with heartburn that have no hiatal hernias. And I've got people with hiatal hernias that have no heartburn. So the heartburn and the hiatal hernia don't necessarily go together all the time.
When you say someone's flunked to their medical management of heartburn, we're talking about people who are on PPIs and they're still spilling acid. They lay down at night. They've got lots and lots of reflux and even wearing out their molars because the acid is so bad. If they... is there a duration of like less than optimal maintained GERD that might need the we're talking about like Nissen fundoplication with like a possible fix?
Yeah, I kind of use 2 episodes a week of legitimate. Now, there's a difference between heartburn, which is a symptom. You're going to say it hurts. It's not even. It's one, not your heart. And second is it's usually don't describe it as a burning. They typically describe it as a pressure or, an uncomfortable sensation. And we just call it a burn, I guess, versus GERD or GERD, gastroesophageal reflux disease. There's a difference between those two. So I can have somebody that says, yeah, I've got these symptoms that are, just under my understand that's pain or pressure, a fullness. Sometimes my food doesn't quite hangs up a little bit, versus the person that might say, I don't have those symptoms. I lay down at night and I got a sour taste in my mouth. I wake up choking and coughing. I've got dental problems. I've got sinus issues. There's a lot of things, but they'll say, I don't have any heartburn. And so they're having reflux. And so we do those, although ultimately can be treated, ultimately end up in the same treatment categories. The symptomatology is different. And it's just people got to understand that if you wake up with sour taste in your mouth, or you wake up choking and coughing, or in the adult onset asthma is GERD until proven otherwise. They don't have lung troubles. They have reflux problems. They've got GERD coming up, and they're inhaling little teeny micro droplets of acid that sets their lung off. Yeah. So, and that's adult onset asthma. That you don't go treat the lungs, go treat the stomach.
So more than 2 episodes a week, are you looking at maybe doing a repair there?
Yeah, if you're on maximal medical therapy, or you don't take your medicine right, you can't afford the medicine, your insurance doesn't cover the medicine, it doesn't matter what the reason is that you're still having more than a couple episodes a week that's consistent. You flunked medical therapy. No therapy, not doing anything isn't therapy. So I don't include that in a treatment option. So if you've gone through all of that, then you've flunked, then we offer surgical management. And the story's really simple. I mean, you guys this is the surgery patient. I started a while ago, and I was taking Tums and Rolaids, and they worked really good. And then pretty soon I blew through that, and they weren't effective anymore. So then I started taking, back in the day, Tagamet and Zantac, and I
Prevacid now, I think.
Yeah, it's
H2 blocker.
Yeah, and so I started taking that stuff, and it worked really good for a little while, and then I blew through that, and then I end up on the proton pump inhibitors, or the PPIs, and this is your omeprazole, the Nexium, Prilosec, the purple pill, and that, Protonix. Yeah, I took that, and man, that was great, and it worked really well for a while. You're starting to get the pattern, and then I blow through that, and it's not working. I'm still having symptoms. I'm having breakthrough. And so then those people have now failed medical management, and I think surgery is a really good option. And we do them laparoscopically now, and it's essentially a same-day surgery, and it's really effective if it's done properly. I would suggest that you have it done by a surgeon who is experienced, or doing it with somebody experienced, so that you get the results that, because everything has negatives, and if it's not done right, you can actually be worse and rather have your heartburn than the symptoms from gas. We call gas bloat. You can't burp. You can't swallow because the wrap was too tight, and things like that. And all of those are technique issues. That if the surgeon is just cognizant of those, you're going to be fine.
So we typically, in primary care and family medicine, we typically will screen these folks every 5 years with an endoscopy, make sure they're not developing precancer called Barrett's esophagus. Yes. If their symptoms are prolonged and persist, surgical options, but also, there's a lot of folks that are scared of the surgery. Yeah. But honestly, the medicines, to be on a PPI your whole life or for 40 years, the PPI decreases the acidity in the stomach. Acid is necessary for the absorption of certain ions, especially like calcium. Mm-hmm. And so people become osteopenic and osteoporotic, and iron. And so then they're fatigued out, and their ferritin levels are low, and a lot of docs aren't even checking ferritin because they're checking the hemoglobin, and they're like, it looks good to me. Yeah. But if they're on a PPI, we should be screening those things, looking at that. And the long-term effects of being on one should be discussed as a risk-to-benefit ratio versus this procedure.
Surgery. Yeah. And you bring up a real good point. Everything we do has risks. Surgery has risks. Medication has risks. Not doing anything has risk. The question is, why should I care about heartburn? And I'll tell you, heartburn is not, it's just heartburn or reflux symptoms. It is not a benign condition. The good Lord gave you one esophagus. That's it. And if you ruin it from continued exposure to the acid, you can have scar tissue develop. We call Schottky's rings or strictures, where it narrows down and then we have to stretch it. And once you get the scar tissue, you own it. It's not like scar tissue goes away. And it can get worse over the years. And then you brought up Barrett's, which is a pre-cancer, and it's real. And esophageal cancer is not one of the cancers you want. They're bad actors. We don't have very good treatment, and typically you get it and you get it, and it's what'll take you out. So, and you only get one chance. So don't look at heartburn as it's just heartburn. It's something over the counter, and not and just treat it kind of haphazardly. I'd suggest that you talk to your doctor about it, get scoped, make sure that you know what you're treating. Not all heartburn is benign. It might be a growth down there that's giving you grief and not heartburn. Mm-hmm. So it's something that anybody on over-the-counter medicines for more than a couple years that you're taking Prilosec because I need it, and I've not talked to my doctor about it, I think you need to be bringing that up, and you need a scope.
Yeah, for sure. Thank you so much. This is good. We kind of
we did,
but that's okay. I love that stuff. I think it's leaving space for those kinds of discussions. They're valuable for lots of people because heartburn is super, super common.
Very common.
And if there's a reasonable solution that's mechanical for this, then awesome.
Yeah. Well, if you catch things early, and this is the whole deal, if you want to be an ostrich, put your head in the sand, I'm telling you, it's going to be far more expensive, and the results are going to be far less superior if you wait than if you go in and get it treated. For instance, Barrett's, before it turns into cancer, we've got treatment for Barrett's where you can do radiofrequency ablation and actually get rid of the Barrett's, just like a polyp in your colon. Mm-hmm. And the risks of cancer are almost the same as a colon polyp. And we take those off, and everyone understands that. Yeah. So do I want basically a flat polyp in my esophagus? And so we have these treatments. If you address them, don't ignore it because it's just going to cost you more. Yeah. Time off work, money, and then the results aren't as good.
Do you do treatment for Barrett's and all that?
We do. That's yet another discussion.
Yeah, because GI and gastroenterologist.
Yeah, that's another discussion. But the point I wanted to bring out is there are treatments for these when we catch things early on, and the treatments are very, when they're early, it's a lot easier to deal with. It's I guess kind of like a car tire, it's starting to wear out. You can go replace the tire and just buy the tire, or we can let it go out, let it blow out, and then you ruin your rim and the rubber goes up through your fender and it takes out the side of your car. And, it's like, geez, if I just replaced it when it was a problem, I could have saved a lot of headache.
I love it.
And it's the same with the hernias. If you're don't put it off. And this is a guy thing. I'll bet you 75% of my guy adult patients that are married, they're there because their wife made them. Not because they wanted to be there and it was like their wife was just on them and their wife was right. Don't put it off. Just go get it done. It's really straightforward. Don't be afraid of it. Just be knowledgeable and get it done. And
this is a guy thing.
This is a guy thing.
I've seen some things that I'm like, this thing is the size of a grapefruit. Like what? It was much smaller 10, 15 years ago.
Oh, let me tell you, this just brings up real quick. I had a guy that came in with, a hernia. Remember, it's a hole, an intestine goes out and it goes down through the inguinal canal into the scrotum. And so
pay attention, folks, because when a surgeon says I've got a story, it's going to be good.
Oh, this is good. So this guy comes in and he had I think he believed he was just well endowed because his scrotum was massive. In fact, and this went so long that he wasn't in because he wanted his hernia fixed. He could no longer put pants on. his scrotum was like a watermelon, and he couldn't put clothes on. He was in because he couldn't get his clothes on, not because the hernia was there. I was just looking at him like, how does this happen?
Yeah.
And I know how it happens is we're just guys. We don't want to take the time. It's just inconvenient. We've got 100 reasons. I'm just telling you, you're going to regret it. Just go get it done when it's simple, straightforward. Literally, it's a 30-minute procedure.
Yeah.
And you go home and you're done. I have my patients for inguinal hernias, full duty, whatever you want to do, 2 weeks.
Yeah.
Just give me 2 weeks. But in the 2 weeks, you're still doing normal stuff. You're just not doing strenuous stuff.
That's great.
But anyway, yeah.
Great story. Thank you.
Yeah.
So I just want to put a final plug in. We don't have time to go into bariatric surgery. That's going to be another time.
We can do that.
You're a wonderful guest. I appreciate you coming out. But I want to talk about just underlying visceral fat and this abdominal obesity that occurs, and just in less than 5 minutes. This puts pressure north to that hiatal hernia, but also to the reflux and to the esophageal dysmotility. And then it also puts pressure south. You've created a sac on your abdomen, and your abdominal sac is like getting pushed and bubbled out more and more and more. And it's more pressure for these holes to form, or even to chinks in your armor to just have some herniations.
Yes. The visceral fat, again, that's a topic in and of itself. Men hold their weight on the inside. This is just kind of typical. Men will hold it on the inside. So if they tighten up their muscles, you can feel that from the skin to the muscle often is thin. Not necessarily at their pannus, but when you get further up. Whereas women hold their fat typically on the outside of their muscle. So the way I remember it is we like our women to be soft and cuddly, and they are. Their skin's soft and they've got that fat on the outside. When you look on them on the inside, they're skinny people by and large. Men are not, and that's why we have a lot of times with men, they have the fat around their organs. You can think of it as they have higher heart disease. They've got, all the abdominal fat issues, which can be related to testosterone levels and a whole variety of different things. But yes, the fat is putting pressure 360 degrees. And, the other thing, and don't underestimate this, for every pound excess weight that a guy has, and I guess for women too, it puts 4 pounds of stress on the back. Every pound, it's a lever. The further out you go, it's a lever action. So every pound is 4 pounds of stress. And so you're going to end up, having more back pain, disc problems, and like I'm saying, get rid of it. Do all you can. And again, that's, do your best and talk to your doc about.
We talked last time about eating around the grocery store.
Yes,
the outside,
yes, we did.
The vegetables and the meat,
the perimeter of the store.
Perimeter. Stay away from all the processed crap.
Yep.
Yeah, that'll help. Just a teaser for our next episodes, which we'll talk about weight loss surgery. We'll talk about weight loss bariatric stuff. Excited about that one. But Lee, thank you so much for coming on today.
Pleasure, always a pleasure.
This was so fun. Yeah.
Yeah, and just know, I'm giving you my personal experience. This is, I've been doing this almost 40 years, and these are just practical, day-to-day things that I think are just good words of wisdom. But they're my personal opinions.
Yeah, so I appreciate that. And just a caveat, nobody is recused of bias. We had a whole podcast on bias.
On bias.
It's very common, and it's totally fine. But I really appreciate your experience. You have such a wealth of knowledge in these spaces, and to give just good, we don't often have opportunities to talk to docs about just give me the
give it to me.
Yeah.
Well, if be stuff, some of the things I wish I could we should teach in our schools. Honestly, some of these very basic medical things, I don't know why we've kind of got off track in in our education system, but I think through grade school and that, some very basic first aid, just healthcare things. But one of the biggest things that I'm asked is abdominal pain. When do I take my kid in? When do I go in for belly pain? And I think the easiest thing I could tell you, this one pearl, is if you have constant pain for more than 6 to 8 hours, you need a doctor now.
You gotta go.
Now, not tomorrow, now. And I'm talking not crampy pain that comes and goes. I'm talking about it hurts and it's been 6 hours and man, I'm still kind of hurting.
Go.
This is a doctor.
Yeah.
You need a doctor.
Yeah.
So, but anyway.
Thank you. Thanks again. To our guests, thanks for tuning in. Make sure you like, subscribe, share with your friends. Appreciate you.